Hi, and welcome to the virtual annual meeting for the Society for Academic Emergency Medicine. I'm Sarah Kleinschmidt. I'm a senior resident at Boston Medical Center, and I'll be presenting an educational innovation that I implemented with my colleagues Adam McFarland and Laura Welsh. This was an unfunded project, and we have no disclosures. We did receive IRB approval as an exempt study. Just to note, this project was completed in 2019. While we acknowledge the recent progress in discussing racial bias, we believe that many learners will still benefit from the approach that we describe here. We started this project to address provider biases, which are pervasive and contribute to healthcare disparities. While there is increasing attention to bias education, there have not been any published curricula for medical students within emergency medicine. And many of the bias curricula that do exist have shown some unfortunate adverse effects. We know that when we confront people directly about their bias, we tend to create what's called cognitive and affective dissonance. Basically, those who most need the education tend to not understand or even feel attacked, which limits their engagement with the curriculum and can prevent further growth on the topic. This can happen and may even be more common for those with a strong desire to address racism in their practice. So our overall goals were to increase awareness of and management of bias in EM-bound students, but we also wanted to do so with methods that would encourage ongoing reflection and growth. You can see our specific learning objectives here. We began with a needs assessment, including literature review and discussions with students, residents, and faculty. We then developed our teaching methods and module, which was implemented first as a pilot, followed by formal presentation to 5 clerkship cohorts for a total of 55 students and 3 different resident presenters. The curriculum was presented during clerkship orientation, followed by a short discussion and survey completion near the end of the month-long rotation. We made some small iterations to the content and presentation in response to feedback. The module itself was an hour-long session with content and methods outlined here. I want to highlight a few key decisions that we believe supported our final outcomes. We know that learners will gain the most when they experience some discordance between their bias and either internal or social norms. But this discordance cannot feel so severe or threatening that they disengage from the process. So we begin by reminding students of their empathy and using a video to activate these internal ideals and norms. When we introduce bias, it is very intentionally in a self-directed and non-confrontational manner via a private reflective exercise that we'll explore more on the next slide. We then use a brief presentation to discuss bias and the impact on clinical care, but move quickly to solutions by discussing strategies to minimize bias or mitigate its effects on clinical practice. So in summary, we plan to activate strong positive norms of empathy, then introduce significant but learner-directed discordance, and then offer a path to resolve this discordance through concrete and evidence-based actions. We used extensive partner discussion throughout to minimize shame around bias, while also activating positive social norms. And as a side benefit, these independent reflection and partner discussions were also easier to implement with multiple presenters, as opposed to having to facilitate complex group discussions. We developed and used the favorite patient journal exercise as a key component to introduce concepts of bias and allow participants to explore their own biases in a private and learner-generated manner. Students were first instructed to generate a hypothetical favorite patient and list detailed characteristics representing positive biases. They were then instructed to generate a similar list of negative biases drawn from an imagined difficult patient. Each exercise was allotted 5 minutes, completed privately with an explicit reassurance that answers would not be shared publicly. This is in contrast to many bias trainings that provide participants with explicit, external, and sometimes public feedback, such as through an implicit association test. While this objective feedback can be useful, we also know that it can backfire, causing participants to feel angry, to question the validity of the test, and to question the relevance of bias training altogether. We were aware that we were teaching a broad spectrum of early learners and thus prioritized avoiding resistance that would impact future growth. Certainly, other learners may benefit from a more direct approach that aims towards external accountability. We surveyed our students near the end of the clerkship regarding their experience with the module and the clerkship as a whole. We found that a large majority agreed that the training increased their ability to identify biases, recognize their impact on clinical care, manage their biases, and provide compassionate care to a diverse patient population. A slightly smaller majority agreed that the training helped them talk to their colleagues about bias. We thus conclude that this educational intervention met our learning objectives. In free text comments, one theme was that our methods of reflection and discussion both contributed to learner outcomes by normalizing bias and providing a non-judgmental educational environment. No students reported feeling ashamed, pressured, or attacked by the curriculum, which is in contrast to some prior initiatives. Many learners actually commented that they had continued to explore the session content during their clinical shifts, both through internal reflection and open discussion with peers and supervisors. Some did also mention that this process was supported by encountering a diverse patient population. There are some inherent limitations to this research, including being at a single site, which may self-select both student and patient populations. In addition, we were only able to collect survey data rather than objective assessments of learner bias, their clinical practice, or patient outcomes. I also want to be explicit that this intervention was designed to initiate an ongoing process for learners who are new to emergency medicine and new to discussion of race and bias. It may not be appropriate for learners with more experience in either area, and it certainly should not be used as an isolated or standalone intervention to fully address bias or racism in clinical practice. In conclusion, this was a small study, but we believe we have achieved proof of concept that it is possible to address provider bias in a way that encourages ongoing engagement and growth. We accomplished this with a brief hour-long curriculum that was successfully implemented by multiple different residents. We believe our outcomes were supported by our non-confrontational discussion and reflection-based teaching methods, including the favored patient exercise. I owe a huge thanks to my co-authors, including senior resident Adam McFarland and faculty advisor Laura Walsh. I would also like to thank Vondella Bryant, who was the clerkship director during this intervention, as well as Nicholas Zampariello, who was our third resident presenter. I have a few key references for you to explore, and I'm happy to provide more details to anyone who is interested. Thank you so much for watching. Please stay safe, and please reach out if you have any sort of questions or comments.